Give people another minute or so to join us. All right, well, why don't we get started? So we want to welcome you to Clinical Conversations. This is the last of the series, and we'll return in January 2024. My name is Beth McGinn. I am the manager of the MCPAP program. And I want to welcome you to today's clinical conversation of managing clinical complexity and ambiguity in primary care of child psychiatry. Just a few housekeeping things. There'll be CMEs. I will put up that shortly for all of you who are interested in receiving free CMEs. Our sessions will be recorded and will be available on our website, along with a copy of the PowerPoint slides. It will be under toolkits and resources. Our presenter today will stop for questions at several points and ask you to raise your hand, and we'll unmute you. If you have any questions or comments, please feel free to write them into the question box, and we will answer your questions at the appropriate time. And at the end, we ask that you fill out our very brief survey following the presentation, because we always appreciate your feedback for all future presentations. Today's distinguished presenter is our very own Dr. Barry Servette. He is a professor and chair of psychiatry of the University of Massachusetts Bay State, and has served as statewide medical director for MCPAP since the program's inception in 2004. His career has been focused on the integration of mental health within primary care services, improving access to mental health care, and promoting dissemination of evidence-based mental health practices. And he has been awarded the Simon Wild Award for Consultation Psychiatry with the American Academy for Child and Adolescent Psychiatry at ACAP, as well as Outstanding Psychiatrist for the Public Sector of Psychiatry by Massachusetts Psychiatric Society for his work in development and implementation and dissemination of collaborative models in child psychiatry access practices. He is the vice president, treasurer, and founding member of the National Network for Child Psychiatry Access Programs, and he is the co-chair of ACAP, an economics committee. He is a natural trainer for the American Psychiatric Association and Collaborative Care Model, and he has published numerous papers and lectured widely around the U.S. In trauma-informed mental health practices and the application of health information and technology in mental health service delivery. So welcome, Dr. Servette.
Well, thank you so much, Beth. And could you put up my title slide?
Of course.
Thank you.
Let me just quickly put up our CMEs. And I will also put this briefly into the chat.
So while we're waiting for the slides, thanks so much, everybody, for joining us. I wanted to let you know that actually, in terms of questions and interacting with me during the presentation, what we'd like you to do is just raise your hand, use the hand raising function, and we can unmute you. So you can ask your question kind of just with your voice, and you could also use the chat, and Beth is going to monitor the chat, but either one is fine. So here you see the instructions for the CME credits, and there's a code that you can text over to that number, and then Beth will put that in the chat, as well. But let's get the next slide on, Beth, if you don't mind.
Of course.
So today's talk is going to be very clinical. So this is clinical conversations. So this particular topic is going to be very clinical. And I would like it to be very conversational. So I hope that you feel free to, I'm going to ask you some questions as we go along, and hopefully we can have some interaction. And this particular topic is kind of near and dear to my heart. But this is also the first time that we've done a presentation like this. And so thank you everybody for being a guinea pig here. So if we're going to try to, sort of learn from our experience here, but I'm sort of thinking it's going to be really, really clinically sort of rich today. I'm going to do my best. So the topic is clinical complexity and working with comorbid diagnoses in child and adolescent psychiatry. Beth, those slides on the way?
Oh, sorry. I thought they were showing.
Oh, goodness. I can start with that slide. So here we go. So you can start on slide 2, actually. So here we are. As you know, we have lots of, actually, could you go one slide backward? Because that's my,
sure.
There you go. So we have a set of McPap algorithms, as you know, and we hope that you use them and enjoy them. And they're for particular psychiatric diagnoses, as you see: ADHD, depression, anxiety disorder, OCD, PTSD, and autism spectrum disorders. And so those are evidence-based practices. They're really meant to synthesize, some of the best practice guidelines that are out there from AAP, from ACAP, from other sources. But they're for single diagnoses. And the question I have, which is a rhetorical question, is: do these categories really represent our patients? And so the point that I would like to make is that most of our patients don't fit neatly into those categories. Can you go to the next slide? So comorbidity, clinical complexity, ambiguity in child psychiatry is not the exception. It's really the norm, that most of our patients have more than one diagnosis. For example, for anxiety disorders, 60% of patients have at least 2, 30% have 3 or more anxiety disorders, and most children have a combination of different diagnoses. Here's a list of some of the combinations, but it's very limited. There are many more combinations. And I'm going to pose another rhetorical question: is what are the consequences of the excessive identification of comorbid diagnoses? But not just that, it's that sure, even if there are multiple diagnoses, because many of the patients that I treat and that you treat really legitimately have more than one thing, going on. But how do we treat the multiplicity of these diagnoses, and how do we organize ourselves to address them and to explain them to people? Next slide, please. So one of the problems, or one of the, at least in my view, a problem, other people would consider this to be, a good thing, is that our DSM-5 classification system is designed explicitly to promote the identification of multiple diagnoses. We don't have time to go into why, but there are some methodological and research reasons why it's done this way. However, there is a provision in most of the criteria for psychiatric diagnoses in the DSM-5 that if one particular symptom or sign can be attributed to another disorder, then it really doesn't count. So for example, if someone has bipolar disorder, and is in a manic state and is very hyperactive because they have lots of energy associated with their mania, then that hyperactivity can't be considered exclusively as a symptom, or as a justification for the diagnosis of ADHD. Now, you can have, because ADHD, one of the principal kind of, foundational symptoms is hyperactivity. So in order to make the diagnosis of ADHD, you can't solely hang your hat on the hyperactivity if there is, concurrent manic episode, that you have to make sure that there is a whole longitudinal history of symptoms of ADHD and the full kind of criteria, which include symptoms of disorganization and other kinds of executive function deficits. And so that's an example that shows that you can't just blindly start kind of listing symptoms and then sort of checking off boxes of diagnoses without thinking about, whether or not they are connected to something else, because that would lead you to, even in the DSM-5 system, which really supports comorbidity, that would sort of be a bridge too far in terms of, kind of overusing this concept of comorbidity. There's an exception to that. So for example, if actually this is going to come up in some of the cases that we talk about, but if there's a set of symptoms, let's say you have, depression, and then you have irritability and angry outbursts, and you have negative behaviors associated with depression, if that actually, sort of leads there to be some problems with social relationships and isolation and things like that, which commonly does, then you wouldn't, sort of consider that to be off limits in terms of using that particular symptom as a criteria for other disorders like conduct disorder, or like, other sorts of interpersonal sorts of syndromes. For example, social anxiety, if there's avoidance that kind of comes because you're depressed and you have difficulty kind of navigating social relationships, then that can still be used, as a criteria for other kinds of disorders. Next slide, please. So I'm going to start. I think some of this stuff is going to become more apparent as we talk about patients. So I'm going to talk about one. Today, we're going to talk about two patients. And the first one is Annie. Annie is an 8-year-old girl who presents with anxiety characterized by school avoidance, worrying about going to school, arguing with parents every night over homework, irritability, difficulty sleeping, particularly on Sunday nights, obviously because Sunday nights are the night before Monday, where there's school. So there's really a presentation of anxiety associated with school particularly. However, on the psychiatric review of systems, there's other stuff going on. That Annie has been sloppy and forgetful and loses things. And that's been the case since she was in kindergarten and first grade. She has excessive screen time, that she's very attracted to video games and watching TV, and her parents have trouble managing that. She's had trouble paying attention. She's been described by teachers as being inattentive and really distracted. She's also had some mood symptoms. She's been unhappy a lot, especially during the school year. Ends up being much happier during the summer. She's irritable. She has difficulty sleeping. She has some explosive outbursts, particularly associated with homework sort of arguments and conflicts. In addition, she's socially awkward. She has no friends. She behaves in an immature way, and she has difficulty connecting with her peers. So open up the discussion. What are some of the diagnoses that are suggested? And you can either raise your hand to be unmuted or just type in the chat. Anybody? Next slide. We have a learning disorder in there. Yes, that's a possibility. I should have added that to the differential diagnosis. But on this next slide, you can see, as Marissa M says, that there's signs of ADHD, there are signs of anxiety. I'll add, that there is sign of potentially a mood disorder, which is represented by the irritability, and yes, a pervasive development disorder because of her described difficulty making friends and really connecting with her peers. So here we have at least 4 diagnoses, perhaps 5 diagnoses. Maybe they're all valid. Maybe they're not all necessarily valid because you do have to apply the DSM-5 criteria. But aside from whether or not we assign these diagnoses, all of them, the question is, how should we think about this patient? And next slide, please. So in thinking about these particular symptoms, I'm recommending and really urging people to kind of think through in your minds the context of the symptoms. In this particular patient, as you know, the sleep disturbance, for example, is limited to Sunday nights. The arguing and the irritability is associated with homework. Think about the timing. So those are just examples. There's lots of contextual factors that are suggested in this case. Think about the timing of symptoms. For example, which came first? So the anxiety is in your face right now. It's what's presented to you in the office. However, if you look back in this case at the sort of unfolding of symptoms, the earliest symptoms were ADHD symptoms, particularly the timing of the ADHD symptoms associated with early enrollment in school and organized programs. So that's also the age of onset. And you have to consider matching, the symptoms with what we know about the natural history of specific syndromes. For example, ADHD tends to become apparent in early childhood. If someone presents with ADHD later in childhood, then that suggests that maybe those symptoms could be coming from something else. So the natural history in this particular case matches our theory, as far as the hypothesis that this patient has ADHD. Also think about the severity of symptoms. The anxiety is kind of upfront, in this case. And so that might lead you to think of the anxiety as something that needs to be treated as a primary diagnosis. However, that has to be in conflict a little bit with the fact that the anxiety is associated with things that are impairments associated with ADHD. Thinking about developmental history, which goes back to the question of ASD or autism spectrum disorders. So when a child presents with social deficits, if those social deficits are beginning very, very early in life, even at the age of 2 or 1, during infancy and toddlerhood, then that kind of speaks to, that there is a developmental disorder here, such as an ASD. You can also consider genetic factors. And then lastly, you can consider responses to interventions. For example, if you were to have a patient, who you thought had an anxiety disorder and you start treating them for anxiety, when the main problem is ADHD, then that's probably not going to help a whole lot, because when you treat anxiety, unless you're treating with a benzo, which we don't recommend, the SSRIs wouldn't really work if the anxiety is related to impairment in school performance and in paying attention and organizing and things like that. So these are examples of how we try to put together sort of a hypothesis about the relationship between different symptoms rather than just generating a list of diagnoses. Next slide, please. So here are some counterfactuals, and these are not necessarily the case, with this particular patient, but just for the sake of argument, what if Annie's mood symptoms were associated with suicidal ideation and anhedonia, loss of interest, and consistent negativity? So if you have like a very full and severe syndrome, especially associated with potential risk of harm, then that's going to lead you to sort of put the depression diagnosis front and center. That's not certainly the case with Annie's presentation, but that's a consideration. Next slide. I said this before. What if, well, Annie is not 13, she's only 8. But what if she was older and the symptoms of inattention and disorganization began at age 13? Well, that doesn't match, the natural course of ADHD. With some exceptions, there's some patients with ADHD who are missed early in their childhood because they have other strengths that obscure the manifestation of the ADHD symptoms. If they're highly intelligent, they can sometimes maintain school performance and things like that. And especially for girls who are less likely to have hyperactivity, oftentimes ADHD is missed because they are not noticing in school the inattention as much, because the hyperactivity is usually much more noticeable. And then it might be kind of overcome by a high level of intelligence. We see this actually pretty commonly. So that's an example of how we use the age of onset to try to sort out what to think of certain symptoms. Next slide, please. So what if the social impairment, was more than just difficulty making friends, but really had some more profound kind of stigmata, if you will, of autism spectrum disorders, such as idiosyncratic interests and repetitive behaviors and poor eye contact and delayed speech. We didn't hear about this in this case. We only gave you a vignette. But if that was the case, that would lead us to really take the possibility of autism spectrum disorders much more seriously in this case. Next slide, please. I wanted to introduce a concept that I think about a lot, and this is sort of different approaches to diagnoses. There's the lumpers and the splitters. I'll sort of confess to you right now that I'm a lumper. I like to sort of think about the relationship of different symptoms with each other, and I don't like to think of children as having a whole bunch of different diseases, to be honest, because I think children don't. I think the diseases that we identify in children aren't separate things, but usually they're often kind of related to each other. And so I'm encouraging you to be lumpers like me. You don't have to, because there's lots of splitters out there, and there's plenty of support, for, sort of generating lots of diagnoses. But I want you to ask the question to yourself when you're treating patients: do different symptoms represent different facets of a single syndrome, or are they separate diseases? And the way to do this is by having a formulation. Now, the term formulation is often not used in teaching mental health to primary care. It's used providers, it's used more for psychiatrists, but I believe that the formulation is actually very helpful for primary care providers as well. And having a formulation really means developing sort of a narrative for trying to understand the relationship between different symptom complexes. And I would add that when you do this, it's going to influence the way that you explain, what you're treating to children, teenagers, and parents. The way that you explain to teachers, it's going to guide your treatment plan. It's going to result in better treatment plans that are more tailored, to the needs of children. It's also going to prevent you from having an overly inclusive treatment plan, if you will. Inclusive is not the right word. An excessive treatment plan, because we really want to avoid giving kids too many medications, giving kids too many classes of medications if they don't necessarily need it. I would also say that lastly, that don't worry about having the wrong diagnosis, because diagnosis, even among the most sophisticated child psychiatrists, is iterative, meaning that it becomes more accurate over time as we learn. And it's particularly often in response to empirical treatments that we provide. So have a hypothesis. Feel free to have a theory for what you think is primary, what you think is secondary, and then to tailor your treatment plan to the conditions that are primary, that you think are foundational to the other symptoms that you have. And I'm going to give you a little bit more sort of application to this case in the next slide, please. So here's the formulation for Annie. And this is a proposal, for you, and you might have a different way of thinking about this. But the way I would think about it is, in terms of sorting out what's primary versus secondary, for Annie, I actually feel that there's a lot of evidence in this case that the inattention and the executive function deficits are primary, and that they lead to anxiety and avoidance symptoms because kids don't like to be to fail. They don't like to be incompetent, in situations and their social settings and their relationships with teachers and things like that. And so it's very painful, and it often leads to discomfort, worry, and avoidance of schoolwork. And as you can see in Annie's case, that avoidance and discomfort has led to conflicts and strains in the relationships with her family, which has an impact on social self-esteem and social adaptation, and it has an impact on mood, causing dysphoria. And then the social skills deficits often arise from the difficulty with attention and self-regulation from ADHD, because kids sort of need to use lots of executive function skills in order to relate to other children. If one child is very distracted and another child is more focused, it becomes very difficult for them to fit in. And so that's my theory, in this particular case. And what are the implications for treatment? Next slide, please. So if we have this theory, then we might begin by treating ADHD as the primary problem. Now, we would consider the anxiety and avoidance behaviors to be secondary to the ADHD. They may require their own treatment, and we need to address them, especially if they are front and center and really getting in the way and develop a certain life of their own. We might even assign an anxiety disorder as a secondary diagnosis, which is perfectly fine. But if we have a theory that says that the ADHD symptoms are the primary problem, then we would sort of treat that first. And then we would not use meds, for the anxiety, right out of the gate. We would start with individual or group therapy to try to help modify the anxiety and the avoidance behaviors. We might apply the same individual group therapy, not a separate therapist, to try to address self-esteem issues. We might provide parent guidance therapy, which is ordinarily provided by the same therapist that does individual and group therapy, to try to work on improving relationships with parents, because that problem, doesn't solve itself, just because you begin treating the ADHD. Catching up on social skill development, we've sort of hypothesized that the social skill deficits are not, necessarily signs of ASD. And so they're secondary to other kinds of developmental experiences. So we might think about occupational therapy, a social skills group, a recreation group, to try to build social skills. And then, of course, with ADHD, it's very important to consider educational accommodations and to make a recommendation for a 504 plan. So that's Annie. I wanted to move on. Why don't I pause, for any questions before I move on, because I'm going to start talking about another patient. Okay, I will move on. So the next case study is a boy named Andrew. So he's 13 years old, and the presentation, the upfront presentation is that he has aggressive, disruptive behavior at home and at school, violent outbursts, a lot of concern. And the violence is towards peers at school, particularly, not towards teachers at this point. Restless, impulsive behavior. Upon evaluation, an interview, the patient reports sadness, hopelessness, suicidal thoughts, The parents described Andrew to have a loss of interest, anhedonia, sudden decline in academic performance, and conflict with siblings. And the onset has been over the past year. So this has been going on for not forever, but for a significant length of time. Additional history that was gathered is that there was a death of the patient's grandmother who lived with the family after a sudden illness 1 year ago. I will mention that the parents have had a lot of negativity in their relationship with Andrew. However, the grandmother was always extremely attached to Andrew, and Andrew was attached to her. There's also additional description of Andrew being cruel to the family pet. He has a history of difficulty sitting still and attention since kindergarten. He has a history of domestic violence, witnessing in the home. Parents are now divorced. The father is recently in recovery from alcohol use disorder, and things were very chaotic and scary, for Andrew, particularly at the age of 2 up until about 7. So I'm going to stop for a moment, and I really am counting on you guys to give me some ideas for the differential. Let's see in the chat. PTSD, yes. What else? Depression, ADHD, a little bit of ODD. Anything else? Okay. Next slide, please. Oh, substance use. Absolutely. That's a very good point. He's 13, and that needs to be considered. Next slide. So, guys are good. In the last case, you added the learning disorder, which I had neglected to include on the slide. In this case, the substance use disorder was added too. That's a possibility. I will say in this patient that there is no evidence of substance use disorder. So these are the things that I would think need to be considered. So there's the possibility of a depression. There's suicidal ideation. That particular symptom is very concerning and obviously associated with significant risk. Perhaps he's having a complicated grief reaction. There is a history of ADHD that seems to not have been treated at an early age. There's the possibility of PTSD from the witnessing of domestic violence. And then there's signs of an emerging conduct disorder, which is a grave diagnosis because it has a poor prognosis and is associated with cruelty to animals and to disrespecting other people's needs and feelings and having all kinds of aggressive behavior that could be resulting in delinquency and involvement in the correctional system and things like that. Next slide, please. So some considerations. What symptoms are most so the point is that we need to sort this out. That we need to sort out. What is the right diagnosis? Do we want to have a list of diagnoses in this particular patient? Do we want to think of some of these diagnoses as primary versus secondary? How do we explain this to people? Really. So one place to start, in terms of treatment planning, is you want to identify what are the most severe and concerning, symptoms, and pervasive, another word. So obviously in this particular patient, the aggression is very concerning, and the depression, and aggression and depression are very intertwined. And so we might think of depression, as kind of something that's the most concerning target of treatment, that we want to address that. That's what we're being presented with, that we want to treat this patient for depression and try to address aggressive and disruptive. That's what I would do, in hearing about this case. However, what about the age of onset of symptoms? So there are also ADHD symptoms that started in early childhood. There was trauma that was experienced in early childhood. That's not, a symptom, but that's just a contextual environmental factor. Um, and then the depression started about a year ago. So he's 13, so it started around 12, which does match what we know to be the epidemiology of depression. That depression tends to emerge around sort of in the teenage years and the pre-adolescent adolescent years, and so that's something that should be sort of considered and on your mind as you're thinking about sorting out these diagnoses. What about the timing of the symptoms in relation to environmental stressors? For example, the death of the grandmother, who was very important to Andrew, and it was sudden. It was probably a traumatic experience for her to die of a sudden illness when it was not expected. And so that's kind of another consideration that might lead you to have a way of thinking about how this depression seemed to occur. And I guess the last consideration is that it's very important to interview patients, and that may seem like it goes without saying, but particularly with mood disorders, that it's really important to understand the subjective experience of patients in order to understand sort of what their needs are, what's going on. And this particular patient was able to disclose feeling very sad and hopeless, and did talk about suicidality, which you would not be able to assess, just based on reports of parents and reports of teachers and things like that. Next slide, please. So a few counterfactuals, and again, these are not characteristics of this case, but they, are possibilities that you would want to know what to think if they were the case. For example, what if an SSRI trial caused a severe worsening of agitation, aggression, in addition to grandiosity and a sudden onset of a severe sleep disturbance? What would that make you think? Um, I'm looking in the chat for any answers from you guys. Um, Bipolar disorder, yes. So that would make you think bipolar disorder. And what if a secondary degree relative, actually that's the same, this was meant to be a combination, had a history of chronic mental illness with multiple psychiatric hospitalizations, which could be a sign of a family psychiatric history of bipolar disorder. Oftentimes you never know, what the diagnoses of family members and ancestors are, but you have to kind of have some inferences, or you try to make some inferences about that. When you see patients with chronic multiple psychiatric hospitalizations, that could be bipolar disorder, it could be recurrent depression, could be schizophrenia, it could be some kind of personality disorder, but that the most common cause of that, I would say, is likely to be bipolar disorder. So next slide, another counterfactual. So what if the aggression and disruptive behavior at school was occurring in the context exclusively of relationships with teachers known to have intense and uncompromising disciplinary style? So you have tough teachers who are very strict disciplinarians, and he is reacting to those teachers and becoming aggressive and disruptive. But with other teachers, he's much more cooperative. Also, what if he's been shown to have bullying behaviors? And actually, particularly for this particular counterfactual, I'm going to say this is part of the presentation of this particular patient. So Andrew's aggressive and disruptive behavior is certainly occurring, especially, not exclusively, in the context of these relationships with certain kinds of teachers, and that he is showing bullying behaviors. He's kind of targeting some of the vulnerable peers and being cruel to them as well. So that would speak to what these particular features. So the first feature would speak to PTSD, that he has a history of complex trauma at an early age, and he is being triggered by teachers who are being very strict and critical of him when he makes a mistake. especially with his history of ADHD, is more likely to make mistakes and need to be corrected and redirected. And so certain teachers do that in a very gentle way. Other teachers do it in a very strict, and punitive way. And he is triggered by those reactions and is showing signs of PTSD, with those behaviors. And then the bullying behaviors, he is certainly, that's often a sign of PTSD when kids are reenacting victimization that they have experienced in their lives with others at school. So this particular what if is yes, that he has those particular features, which would certainly lead us to think more about PTSD. Next slide, please. All right. So in sorting out, this patient, after making some of the considerations and thinking about some of the complexity here, we've identified that ADHD is a likely, diagnosis. PTSD is a likely diagnosis, and there's some kind of mood disorder. He's got suicidal ideation. He has pervasive depressive symptoms. He's irritable. And so what I'm recommending here in terms of how to think about this patient is to not treat this as a simple kind of blind list of syndromes, which would ordinarily lead people to sort of throw the book at him, basically, say he's got all these different things, and then you give him a medication for each thing. So he's going to have a medication for his ADHD, the stimulant. He's going to have an antidepressant. He's probably going to end up on a mood stabilizer because he's so irritable and explosive. And then he'll end up on an alpha agonist like clonidine or guanfacine or Intuniv or something like that for some of his PTSD. Maybe he'll be on prazosin or something like that. But in any case, treating this as a list of diseases, at least, is my point here, often leads to sort of over treatment, with medication. If we think of this as a system where there are relations between the different symptoms, then that could lead to a different, more parsimonious treatment plan, if you will. So some of the terms that I recommend thinking about are vulnerabilities, triggers, what are the antecedents of different kinds of behavioral complexes, and how does the environment, sort of work? How does that influence, the unfolding or the manifestation of these symptoms? Next slide, please. So for Andrew, here's my formulation, at least, as a proposal, because all formulations are proposals. They're not certain. They're theories, and the theories are tested out by interventions and also by sort of when you explain these theories to people, oftentimes you get some dialogue, which might lead you to think differently or might lead them to think differently. So the way that I would put this together into formulation is I would say ADHD. That seems to have been apparent since he entered school. I think of that as a vulnerability, as a constitutional vulnerability. It's really more of a biological, syndrome, and it really impacts the child's ability to cope with environmental stress. And so we mentioned before that at school, the ADHD leads him to make mistakes and to have behaviors that are not appropriate to the situation because he's not paying attention to all the things that he needs to know how to behave appropriately. And that leads there to be a vulnerability to getting triggered. Actually, the ADHD is the vulnerability that leads to the behavioral responses of teachers and parents that get frustrated with him. And when they express that frustration to him, that triggers him because he has a history of witnessing domestic violence and a history of trauma. And so that leads to the next item on the list is the understanding and recognition of the trauma, the impact of the trauma of domestic violence with his PTSD. And so there's an interaction between, the effect of his ADHD in terms of inducing or provoking people to criticize him and to be angry with him and frustrated with him. And then his history of trauma, which has never been addressed, leads him to have disproportionate reactions to these kinds of disciplinary corrections that other kids can handle, with, more, they could be more resilient, when teachers yell at them or if they, get sternly corrected. And so that's an example of the relationship between ADHD causing these negative interactions that trigger him, that lead in turn to bullying, antisocial behavior, um, an adoption of a certain kind of an identity in the social system as a troublemaker. Because once kids experience, being in trouble all the time, they adopt that as an identity, and that sort of ends up causing a vicious cycle, of negative behavior with more correction, and it really reinforces that identity and results in very low self-esteem, which leaves him vulnerable to depression. And then the triggering episode for the presentation was the loss of his grandmother. So that he's dealing with this low self-esteem from his negative behavior, which was caused by his ADHD, and then the negative behavior was caused by the PTSD as well. And then ultimately, he had this vulnerability that ended up leading him to develop an acute depressive episode when he lost his grandmother. That's kind of how I pull the case together. What implications does this have for treatment? Next slide, please. Okay. So this particular example actually is not a good one if I want to say that we should all be lumpers and only give people one diagnosis, because one diagnosis is not going to really cut it, for this patient, because he's got ADHD, he has PTSD, and he has depression, and so all of those need to be treated. But if you think about the relationship between the different syndromes, as opposed to just having a list of diagnoses and then you just give the child treatments for each one, if you think about the relationships between these particular diagnoses, then here's, how I would necessarily approach it. So for example, as I said before, you have to consider symptom severity. So he's got suicidality and depression with significant suicidal risk. And so that has to be the first objective of treatment, is addressing depression and suicidality. So we often treat more severe depression or moderate to severe depression with an SSRI in addition to a psychotherapy referral. So that's going to be the foundation, of his treatment plan, is that he's going to be treated for depression. But the medicine for depression is not going to be considered the primary treatment. It's going to be considered one element of the treatment plan. I would argue that the more important treatment for this particular patient with depression and all these other things is a trauma-informed individual, maybe plus a group psychotherapy, and that's going to be essential. The trauma-informed psychotherapy is going to not be exclusive to the depression, but it's going to be treating him for depression, for self-esteem, for PTSD, for self-regulation from his ADHD. So psychotherapy isn't kind of a sort of a targeted treatment, but it's a really generalized kind of treatment. In addition to that, he's going to need mental health supports at school. Those mental health supports need to be trauma informed, because the negative interactions with the teachers and peers, as we said, is a vicious cycle that's really worsening his self-esteem and contributing to the formation of an identity as a troublemaker, which is the conduct disorder. I would leave the conduct disorder diagnosis off unless I was forced to make that diagnosis because he had so many antisocial and delinquent behaviors that it would be almost negligent to not list it, but I would say that I would think of those conduct disorder symptoms as secondary, not necessarily attributed to the other diagnosis, but being an outcome, related to the other diagnoses. And so I would think of them as symptoms. And I would really want very badly for there to be a school psychologist, at the school to understand this child and to help the teachers to understand his behaviors and to try to identify trauma-informed strategies to manage his behaviors. I think that would be critical in this case. And then, he's going to also need to be treated for ADHD. That's another diagnosis that is a vulnerability that leads, things to go wrong. And so the ADHD treatment will involve a second medication, usually a stimulant, and you can follow our treatment guidelines for ADHD. But the educational accommodations are going to be very important, for that. And I guess the last thing is strength discovery. Strength discovery is something that the therapist would probably do, and I think PCPs can ask therapists to do this, if they are not doing it already. But that really is identifying and cultivating special interests and skills based on the child's strengths, ultimately so that they can begin to address that identity as a troublemaker and to try to shift that into developing other things that he can be proud of about himself, and also developing social skills and competencies for activities that are related to those kinds of problems. And so that's, again, we're not giving him a conduct disorder diagnosis, but we are identifying self-esteem issues that don't correspond to any specific DSM-5 diagnosis. That correspond to lots of them, but that's going to be an important part of his treatment plan. So that's an example of how you could have a relatively parsimonious treatment plan, at least to start with, by treating the patient for ADHD and depression, and then having psychosocial interventions, not just therapy, but also school mental health supports that can sort of address the whole patient. And that's sort of how the relationship between diagnoses can sort of influence, the development of a treatment plan. So I'm going to, next slide, please. So I'm going to go back one. There you go.
There we go.
There it is. So summary of this presentation really is that we have to learn how to navigate comorbidity and clinical complexity in child psychiatry, that it's really the norm, it's not the exception, that most patients, have more than one diagnosis, and that there's lots of interactions that need to be understood between the different symptoms as well as the environmental factors as well, that we want to get beyond just having a list of diagnoses and try to understand, children and their families, particularly understand the relationship between the symptoms and the functional impairments, associated with their presentation, with the causal factors, as well, and have some kind of narrative, really kind of to construct a narrative for explaining sort of the reason why someone is presenting what they're presenting. I would argue that excessive assignment of multiple diagnoses and problems can further erode the self-esteem of children, which practically is a problem for every psychiatric patient. Every patient with psychiatric disorder has damaged self-esteem related to the impairments and the challenges associated with their mental health problem. And then the last point is that having this formulation, it informs your treatment plan. It helps you sort of to put together a treatment plan that makes sense, that's parsimonious, that's not excessive, where you're throwing interventions and too many interventions at people. And it also helps to inform the team, that you're not going to be the only one with an opinion, when you have a team of people who are involved in supporting kids' mental health. But you're going to be an important part of that team. And I think if you have a narrative understanding about how their problems are kind of connected to each other, then that's going to help the team to really work together as a team. I guess the point I would add that in my experience clinically with patients and families, that having this understanding and being able to explain it and sort of convey it to people has a very direct, beneficial, I would say, healing impact on parents and children. Because a lot of times when kids are having these problems, the confusion, lack of understanding about sort of what the nature of these problems is, and how it came to be, and what it's all about, uh, it adds to the suffering. It makes people feel like they're all alone in the world. It makes people feel like no one understands them. And it makes people feel as if they're hopeless cases. When you get a list of diagnoses, a list of medications, and no one is really explaining how it all fits together. And so that's kind of where I'll stop. And we have a few more minutes for questions. Feel free to raise your hand. Easier.
Barry, it's John. That last case is so fascinating because in the context of primary care, think back about what might have been, could we have avoided some of this? Because this is obviously a child who's had problems for a long time. When the parents split and they were having all that trouble, was there any knowledge of that in the primary care office? And did anything happen then? So what do you think about this? Is this a kind of case where you could really think about what the value of primary care being preventative?
It's a great point, John. That's all I can say is that this is a great example of untreated ADHD, unaddressed early childhood trauma, and that could have made a huge difference, in the outcome, and prevented this, pretty florid, presentation. Yeah, absolutely. That's actually why we're here, right, John? Because
Yeah,
this is our opportunity.
if they had called McPap
Right.
back when the
Yeah.
kid was 5 and the parents were splitting up, we might have been able to help.
Exactly. Other questions or comments or feedback, even, because I told you that this is was a little bit of an experimental presentation. I didn't present you with lots of data and studies and things like that. It's really more conceptual.
Barry, Dana put in the chat that was this kid even coming in for his yearly physicals and screenings, which is obviously sometimes the kids that need it most we don't see.
Exactly. I'm going to take that as a comment. And the answer is yes. Actually, he was coming in for physicals and screenings, but there wasn't anything that was really done to do any early intervention, from these problems. So resources for schools. The every school is different, and as you know, and it's troubling, that there are schools that have less resources, but than others, and we're actually, there are some models of providing, mental health consultation to schools that we're advocating for nationally nowadays, and Texas has this amazing program called T-Chat, where they basically provide lots of school consultation, to try to help identify issues that are being seen in the school setting, and make recommendations. But ultimately, the schools, they need to have mental health supports, and increasingly recognize that sometimes that looks like a whole organized program of supports for kids who are at risk. Sometimes kids need to be in separate classrooms. Sometimes they need to have therapists who are seeing kids during the day. Sometimes they need to be running groups, with the kids. They need therapists who are explaining to teachers and who are interacting with the other members of the educational team, so that they can get everybody working on the same page. Because oftentimes the problems at schools happen because there's so much inconsistency with how the children are being managed. We have Corin, who says that it's important to be mindful of the place toxic stress is in the lives of our patients, and it can often mimic things such as ADHD and ODD. Absolutely. Thank you, Corin. So I think we're out of time, But thank you for allowing me to use you as guinea pigs. I hope that you found something useful in the presentation. And if you send other questions, I'll be glad to answer them over the email. But please give us feedback about this because we wanted to know if people want more of these kinds of presentations as we go along in the series. So thanks, everybody.